And so with that background of what's happening in our birthing hospitals, I'd like to transition to our next keynote, which will be given by Dr. Elisha Wachman, who is an associate professor of pediatrics at Boston University School of Medicine. She's an attending neonatologist at Boston Medical Center, and she's the physician lead for the Massachusetts state effort focused on care of opioid-exposed newborns. Dr. Wachman is funded by the National Institute of Drug Abuse. She has a long track record of working closely at multiple levels with different organizations focused on care of opioid-exposed newborns. And truly, she goes from bench to the bedside and beyond. And so I think we'll get a sense of this from her talk. And today she'll be focusing on how we engage families impacted by perinatal substance use. And she will teach us some lessons from the Massachusetts experience. So I'm going to stop sharing now so that Dr. Wachman can share her slides.
All right. Can you guys see my slides okay? All set?
Yes,
Perfect.
we can.
All right. Thank you so much, Susan. I know Susan and I have been talking about this for years. I really was hoping to come out to Colorado to meet with you guys, maybe someday. But I really want to thank you guys for this opportunity to come and speak with you today. And when I was first asked, I was really struggling to figure out what I could possibly share with you guys. I know I called Susan, I'm like, what can I teach you guys who are really national leaders in this area with all of the wonderful work that you have done? But I thought of a couple of things. Just wanted to share experiences about engagement from Boston Medical Center and also from some other statewide efforts. And hopefully there's something that you can take from this to use in your own practices. So I have no conflicts of interest to disclose. And again, do want to acknowledge my funding, both from the NIH and the Public Health Informatics Institute. So I am going to be talking today about engagement across the continuum of care. So starting in pregnancy, going through delivery, and then in the postpartum period. And of course, this talk would not be complete without first talking about how engagement is so much harder now in light of what has happened with COVID. But just first, a little bit of background about our collaborative. And so we in Massachusetts have a collaborative very similar to you. It's called the Pinquin Collaborative, and our specific project is called the POP Project, Perinatal Opiate Project. We have a collaboration with 37 birthing hospitals across the state, as well as state agencies such as our Department of Children and Families, Department of Public Health, all working together. We hold summits and training workshops, do a number of webinars, have online toolkits for hospital teams. And we've been working on a lot of very similar efforts, specifically how to engage parents and mothers during pregnancy, after delivery, and this focus on rooming in, ESC, and non-farm care. So I'm going to start by talking about COVID and the impact that this has had on care and engagement. And so first, thinking about mom and some of the things that we have seen at our own hospital in Massachusetts and also across, and also specifically at Boston Medical Center. And so one of the key things that we've seen is that women are really presenting very late to care, often in the third trimester, and coming in less frequently. There's been this big loss of in-person counseling and group therapy, which we know is so helpful. We've also seen this big shift in treatment for maternal OUD. A lot more women are choosing methadone as opposed to buprenorphine, likely linked with the increase in fentanyl use. So we have seen big shifts in those practices as well. And as Stephen had mentioned and Susan mentioned earlier, we've seen a big increase in illicit drug use, relapse, and overdose across the board in the past year. Loss of social supports. And, even though telemedicine, is great in some aspects for our population, we've seen a lot of difficulties. A lot of our moms don't have a computer, they don't have enough phone minutes to be able to participate in visits, and they worry about things like privacy for the 25% of our moms that are in residential care. And so it does have some limitations as well. So with all of this, we've also had changes in our infant care. So one of the biggest losses is obviously our cuddler programs, and I'll talk about that in more detail a little bit later. Also, this is something that happened to us at Boston Medical Center, but we lost our pediatric unit because of COVID. And there's been a lot of changes in terms of visitation and things like that, which has limited optimal non-farm care. And so we were able to look at some of this data actually across the Pinquin Collaborative. And so this is work that was led by Kate McMillan, who is one of the pediatric hospitalists at Mass General Hospital. And she's going to be presenting this at PAS this year. So we looked at 19 hospitals across the state. It was 5 academic centers and 14 community hospitals, and really wanted to see, if we could detect any differences in the year before COVID to this past year. And interestingly, when we looked at the state as a whole, there really were not significant differences. And again, we're shocked that the majority of our moms are in treatment still, near 90%, which is really phenomenal to the work that's been done, in Massachusetts that's continued, over this past year. We did see a drop in rooming in, and again, in the pediatric unit utilization, but overall, like not the differences that I was expecting. And similarly with infant outcomes, looking at, pharmacologic treatment rates and length of stay, nothing was really significant. Of course, we have more centers using ESC, which is always wonderful. But, looking at this, I was actually very, very surprised because it was not what I was seeing at all at our center. And so what we are now diving into is that realizing that there is a big difference in the type of center, these bigger academic centers versus the community hospitals, and the impact that COVID has had on care. And so I want to share with you what happened at my own hospital, because I'm wondering if it's happening, for some of you as well. So Boston Medical Center, we are the largest safety net hospital in New England. We have a comprehensive prenatal program called Project Respect, which is a referral center for women with substance use disorder. We see about 100 mother-infant diets annually with prenatal opiate exposure. And for decades, we've had these infants rooming in together on inpatient pediatrics. So they stay with the mom on postpartum until she's discharged, and then they move to pediatrics for continued rooming in. And we've done so much work in the past 5+ years on promoting new breastfeeding policies. We were the co-developers of the ESC Care Tool and piloting things like PRN methadone and changing our monitoring protocols, which I'll share a lot of this later on. But we've done all this wonderful work. In addition, we have a new outpatient program, which has been in place since 2017, which is a comprehensive outpatient clinic that follows these kids after discharge. We're also participating in a number of clinical trials regarding this population. So for many years, BMC has been a leader in this area. But that all changed a year ago. And so what happened? So this is a headline from just over a year ago. So BMC was the first hospital in Boston to hit ICU capacity in the setting of COVID. During the peak, we had about 300 inpatients a day. And essentially every unit was converted to an adult COVID unit. So our pediatric unit completely closed and all the kids were sent over to Boston Children's. The cuddlers were, of course, gone. Our OB clinic actually turned into an adult COVID ward. And Project Respect transitioned to almost entirely telemedicine. And so the babies with nows. So luckily the NICU obviously was still open in postpartum. And so the babies had nowhere else to go aside from hanging out with me in the NICU. And so here is BMC, and you can see here, looking at 2020. So now we went from having, just a small portion of the kids ending up in the NICU, either because they're preterm or because because of, some transient issues, low blood sugars, things like that, to essentially near all of them coming to spend time in the NICU. And shockingly, we didn't actually see a difference in our farm treatment rates during this time period, but our length of stay started to creep up. And really, we started to see that all these kids were on standing methadone, 2 agents. The length of stay was going up, of having these kids in the NICU. And just anecdotally, too, the mothers, the majority of them were not in treatment or, were not engaged in care with many sort of illicit drug and polysubstance exposed moms. And I would say 80% of them in DCF custody. So here's me so upset about this and what had happened. And so I think what we are doing now is sort of just starting all over again. So the pediatric ward is now open at half capacity, which still means that the infants are in the NICU. I am very hopeful that that will change over time. I've been, advocating very much with our hospital leadership about how critical this is to get these kids in a place where they can have more optimal non-farm care, and we're doing a lot of re-education. So all of my education now is focused on the NICU and what's going on and how we can adapt the environment to make it more engaging for families. So we're really learning how to do this all over again in this setting, and so there's a lot of work to be done. So let's start with pregnancy and how can we engage these moms before they come in to deliver. So again, at BMC, we're very fortunate that we have this clinic, Project Respect. So women come in from all over the state and they come to be seen in this comprehensive care clinic. So we have a clinic that basically co-locates everything in the same place. So they're seen by the OB, who is also their addiction provider, who prescribes their buprenorphine or works with their methadone clinic. They receive their psychiatric care within the clinic. There's a nurse care manager, a social worker, all of it happens in the same place. So I really feel that our prenatal program is one of probably the primary reason about how we are able to really engage these moms is the care that they're providing before delivery. One of the things I think that's been particularly helpful, even if you don't have a program, obviously like Respect, is that we have been able to actually do initiations onto methadone and buprenorphine in the inpatient setting on labor and delivery. So we admit them if they come in, desiring to initiate on treatment. And they often stay for about a week to stabilize on either methadone or buprenorphine, and then transition to whatever outpatient plan they're going to have, whether that be residential, an intensive outpatient program, or what. And so that I really feel like has been essential. They meet the Respect team when they're there, and we're able to really stabilize them in a place where they're feeling very supported. Then the team in Respect will see them very frequently, so more than routine prenatal care every 1 to 2 weeks. So I do feel like that has been also very, very helpful, is the frequent visits by a team that they are familiar with. And then we do a prenatal consult. And I think one of the differences compared to the way that a lot of centers do it, I know frequently it's either a neonatologist or a pediatrician that comes to meet with the moms to do the consult. We have actually had this role of doing the education about NOWS and the inpatient stay done by the obstetricians. And so I think this partnership with the prenatal providers, that we all know the same information, and it's actually their team that they already have this trust with is actually doing the consult and providing this counseling as part of their routine prenatal care. And so we have a pamphlet that we give them and standardized education that all the mothers have in the clinic. And so a lot of the things that they talk about, obviously what to expect with the pregnancy, talking about the impact of things like psychiatric medications on NOWS, reviewing how the baby will be assessed, going over breastfeeding guidelines, preparing for the ability for them to be able to room in during the hospitalization. And we do talk a lot about the evaluation that's done by the Department of Children and Families. And I can't emphasize this enough because I know many of you do not see these moms before they deliver. So this counseling can start, at the time they deliver. So as long as, these same materials are available in all settings, like oftentimes we're starting this education, when the moms sort of walk in the door for delivery as well. So again, the question, what if we don't have this clinic and mom doesn't receive care? And so I think, again, these standardized materials, educating everyone across the board, the labor and delivery staff, the postpartum staff. So we have, this is our handout that we give to the moms, sort of giving them a very concrete list of things that they can do. I think has been really helpful to have these available in all of our care settings. And we emphasize the same language with everyone. So, 5 years ago we used to say, be here when you can. Where now we say, you are the primary treatment for your baby. We want you here. And so I have to tell you, just in our change in our language and how we're presenting this to moms, you just see the mom's face light up when you say this. Like, we want you here. You're an essential part. You're going to do all of these things to help your baby. And, that really helps decrease a lot of the guilt that they might feel, and really helps to engage them from the start, just in the language that you use. I think before, when we were using Finnegan scoring and having them separated, they really very much verbalized to us that they felt like outsiders. They didn't know what their role is. And now I think, emphasizing, what they can do, giving them a concrete list of things has been extremely beneficial in boosting their self-esteem, their empowerment, that they can do this and they can help their babies. And we also share with them the data, as well, and not these graphs, but we share, it's really, really important that you being present, to whatever degree you can, is going to really make a difference in the baby's outcome as well. So this is a study that one of our residents did a couple of years ago, measuring length of stay, scores, amount of morphine, and showed a direct correlation with the percent of the time that there was a parental caregiver at the bedside, and a decrease in all of these key outcomes that we were measuring. Some of the other things that we've done over the years, which I feel have been really beneficial, is that a lot of times mothers would share with us barriers, like, I want to be here, but my program says I can't. I need to go be there between these hours for group therapy. I need to be there at night to check in. Um, or I need to travel 2 hours to my methadone clinic and back every day that I can't stay. And so we did a lot of outreach with these various organizations, so they would understand why it was so essential that the mother be present. So we presented to the residential programs, we presented to the Department of Children and Families, and shared all this data about rooming in and breastfeeding, and why that the most important place that the mother can be during this first week after life is really with the baby. Um, we also make an active effort to guest dose their methadone at the clinic across the street from us, at Boston Medical Center. And those arrangements are made during the pregnancy, so that they don't need to go 2 hours away. They need to go across the street to get their dose and come back. And that has been really, really beneficial to allow mothers to spend more time with us. Transportation has been identified as a really big barrier for so many of our moms. And so anything that we can do to help with that has been really appreciated as well. And just being their cheerleader, if they're, mentioning that they have this particular barrier, offering to call their program, call their DCF provider, I think has really gone a long way to establishing their trust in us as inpatient providers. So I know this is an area of focus of your collaborative, and I did want to just share the data that we have on engaging women of color from Massachusetts. So this paper was published last year from our PinQuin data, and really just highlighted the really striking differences in mothers who are receiving medication for their OUD. And you can see, how significant the difference is in mothers who are Black and Hispanic in terms of not receiving this standard of care treatment during pregnancy. I think we actually did not see any other differences in our NOWS outcomes and any other major outcome that we were tracking in this population, but really where we were seeing the differences is being able to engage them during the pregnancy. And so there's a lot of theories as to why this may be, whether there's socioeconomic differences, could it be differences to access to buprenorphine providers? Um, But I think more likely than not, it is likely fear and stigma about these medications in pregnancy, bias and discrimination and fear of things such as child welfare reporting. But again, all of this are just theories as to why these women are not presenting for care. We don't have a lot of great information as to why. And so one of the first steps that we're taking here in Massachusetts is trying to just ask them to conduct some qualitative interviews to understand the cultural norms of in women of color who use substances and identify what their barriers are to treatment so we can identify interventions. So we are just sort of at the beginning of this project. So unfortunately, I don't have any bright solutions at the moment to share, other than the fact that this is something that in our state as well, that we are seeing these differences in outcomes between the groups, and something that we are actively working on trying to better understand so that we can develop appropriate interventions. So moving on to delivery, and when they come into delivery, what can we do to better engage them in this setting? And so I don't need to tell you guys this. I'm sure you've seen this slide or similar slides before. We know that the best thing we can do is to keep them together. Rooming in, as we know, is the most beneficial intervention associated with significant decreases in the need for treatment and length of stay. So whether you are taking care of these diets in postpartum or pediatrics or the NICU, I think the most important aspect is finding a way for them to be together. So some of the things that we've done in our NICU is, just thinking about where you're placing them in the NICU. Are they in a pod, a private room? What type of bed are you using? Warmer versus, is there a way that we can make this better environmentally for the baby? And trying to do things like limiting other visitors in the room and clustering the baby's care. And so a lot of this too, again, is really focused on our language and educating our providers about using language that is patient-centered, including parents in the huddle, and this very consistent message across providers. So really important to us that we are doing this the same way on labor and delivery, in the NICU, postpartum, pediatrics, to really emphasize to the moms that they are the treatment for their babies. And so one thing I did want to highlight and give some examples is that one of the areas that we feel like has made the biggest difference is that we found that our hospital guidelines previously were actually not um, the most optimal for engaging families. So I would encourage all of you to look at your guidelines and whether there actually are, hospital barriers to being able to better engage these families. And so we've spent a lot of time over the past 5 years trying to reevaluate these policies and guidelines, using data to be able to better engage families. And I want to share with you some of that. Um, so one of the things that we've changed is our cardiac monitoring guidelines, and I would say this has really made a big impact. And so previously, infants that required any pharmacologic treatment were placed on continuous cardiac monitoring. They were taken out of the postpartum rooms and placed on a monitor in the nursery. Because of the lack of ability for central monitoring in the postpartum rooms. And they were kept on a monitor, pretty much during their entire treatment. Once we started PRN treatment, we started a pilot where they would be on the monitor for about 4 hours after each dose, and when they go back to mom. And we studied this, tracking adverse outcomes all along the way. And eventually we stopped monitoring altogether and are now dosing in mom's rooms, that there is no separation that's gone on. And again, just from our experience and what we've been able to track so far, that this has been successful, has really not been associated with any adverse events, and has been able to promote mom staying with baby during the peak of withdrawal. So that was one area that I know made a big difference for us, versus sort of sweeping the baby away to the nursery, and really that separation during a time when they actually most needed the non-farm care. Um, and then I think the two other factors that have really made the biggest difference is one, ESC, which all of you are fully aware of, and then also breastfeeding. So I'm going to talk a little bit about the breastfeeding guidelines and just give a couple of examples on how this change in our guidelines has made such a big difference in care. And I'll share with you what our guidelines used to be versus what they are now, and how this made a big difference in our ability to engage mothers. So these are two stories, and these are both moms that I took care of in our NICU. And so our previous breastfeeding guidelines were pretty consistent with the American Academy of Breastfeeding Medicine's guidelines, which essentially required the mother to be in some sort of treatment program for her addiction. We required that the mom was receiving consistent prenatal care for the 12 weeks prior to delivery, and that there was no unprescribed drug use for 10 weeks. I think ABM's goal would be 90 days. And so I was taking care of a mom and a baby in the NICU. This was probably about 5 or 6 years ago. A mom who delivered at, I think, 29 weeks. She had been on buprenorphine throughout the pregnancy and had had a relapse, I want to say 6 or 7 weeks prior to delivery, and otherwise had been consistent and met every other criteria. And per hospital policy and our breastfeeding guidelines, because she had had this relapse a couple of weeks or 6 weeks prior to delivery, she was not eligible to provide breast milk for her baby. And we have tried really hard to stick with the policy and to treat everyone the same. We really have tried to be consistent and not to individualize things, because inevitably every provider is going to feel differently, and that's going to lead to different decisions being made. And so we've really tried to be consistent and stick with the guideline. And so I remember I sat down with this mom in the first week, and she very much wanted to breastfeed her baby. And her obstetrician came to me and said, I want to promote this mom breastfeeding. She really wants to do it. And the social worker said, this is our hospital policy. I agree, we need to work on changing the policy, but this is what it is right now. And so I sat down with her and I said, I'm sorry, this is what our policy is right now, is that, because you had this recent relapse, you are not eligible for a hospital guideline. And I shared with her, this is a policy that we are actively thinking about revising and, gathering data. And she was furious at me, and she looked at me and she's like, how dare you make this judgment about me? You don't know me. We lost her. She felt stigmatized her entire time in the NICU. We really did not do a very good job of engaging her. And I think at the time we were also in an open bay NICU where she had no ability to stay with her baby. And so really an unfortunate situation. And so 2 years go by, or 3 years, and we were fortunate to get a grant from the state of Massachusetts to focus on non-farm care and changing our inpatient guidelines. And as part of this grant, we needed to hire a recovery coach who was going to focus on breastfeeding support. And who walked in the door but this mom? And she came to me and I hired her, and here she is. She, at that time, was in recovery for 2 to 3 years, and she shared with us that negative experience in the NICU stuck with her, and she felt, how stigmatized she felt. And I am so fortunate to have worked with her for 2 years. And she provided support to all of our moms and our lactation specialists. And I realized just how wrong I was to not have advocated for her. And so since that time, we have done a lot of work to change our guidelines so that something like this did not happen again. So jump forward now. These are our current guidelines. And again, this is based on research that we've done, which basically showed that the time of relapse before pregnancy had zero correlation with how successful they were going to be postpartum, which is exactly what she was trying to tell me. And what all of her providers were trying to tell us is that you cannot predict what's going to happen. And the main predictors of success were actually the moms that were seeking treatment for themselves. They were in a program, they were receiving prenatal care. Those factors were associated with increased success postpartum. And so now we really look at what's in their milk right now. We do positive and negative on admission to L&D, and everyone is allowed to pump. So if you are positive on admission and you want to be reconsidered to provide breast milk, we have the moms pump for a period of time and then come back for a repeat toxicology screen. And the vast majority of our mothers are eligible per these new guidelines, which we've had in effect now for about 2 or 3 years now. So I'm going to share a very similar story again. Now, this is a mom I saw maybe about a year or two ago since we changed the guidelines. So she was also 28 weeks, delivered a baby. This mom had had some prenatal care, but she used fentanyl up until the day of delivery. And she delivered, and the baby was admitted to the NICU. I remember he was in a private room, and it was a turning point for her. She saw that baby and she said, I'm done. I'm going to go. I'm signing up for this intensive outpatient program. I'm going to go every single day to this program. I'm on prescribed buprenorphine and I want to provide breast milk for my baby. Um, and she was, rooming in the NICU. And I remember meeting with her and she said to me, I'm going to do this. Do you trust me? Like, I'm going to go every single day and I'm going to pump and I'm going to come back and give a toxicology screen in a week. And I did, I completely believed her and she did it. She only left the NICU for those 3 months to go to her program every day and come back, breastfed the baby until the day of discharge and took the baby home. And she felt so supported by us and the nurses because we believed in her. And I think it was night and day. And these two stories just always stick in my mind. And just, a couple years ago, we would have told her no. And just this, our willingness to believe in her and to support her in her decision was really empowering for her and really helped her, I think, in her recovery. Um, and so we know there are times that, that moms can't be here. So cuddler programs, we have actually been able to successfully restart us with the use of medical students because they undergo, the COVID screening and testing, as well as employees. We still have not been able to have our community volunteers back in. So one idea is just to share with folks that if there are folks that are already coming to your hospital, either students in training or other employees, that we have been able to restart the program successfully, actually since September, with that. And so just in the last couple of minutes, I'm just sharing some of the other issues, or not issues, the other ways that we've been able to continue to engage parents, even in these more challenging situations. We have a number of women who are incarcerated, and we really don't do anything differently. They're able to room in until they need to go back. After the mother is discharged, we use the same breastfeeding criteria, and same, the babies who are removed from parental custody, we still really encourage them to be there as long as they can, or to encourage a designated family member to be there as well. So in the last couple of minutes, I do want to just talk about how we've continued to engage moms in the postpartum period. So here is our discharge criteria here. We watch our kids for 5 to 7 days, just given that 95% of our moms are on these longer acting opiates. AAP says 4 to 7. I think the most important piece here is that you are 24 to 48 hours after your last dose of opiate over the peak of withdrawal. So with ESC, we really rely on kids being sort of primarily 1 to 2 ratings for consolability, and that the parents are able to maintain these non-pharm measures at home. One thing we do emphasize, and I know some things that Susan has spent a lot of time thinking about, is safe sleep. And so really having the parents being able to put the baby down in the crib, very, very important before they go home, stable weight and oral intake, and that there is a safe plan of care after discharge. The recommended follow-up, we really feel like these kids need more frequent follow-up in the first month than other infants to look at things like growth and oral intake. And it's important that they are seeing subspecialists for a lot of these other issues that which are listed here. So Hep C follow-up, EI, and ophtho, which I'll talk about in the next couple of slides, to emphasize our sleep education, and also to make sure that the mom has a good plan for recovery. And so with plans of safe care, I'm not going to talk about this in too much detail since you guys have already done so much work on this. I can just share what we've done at BMC is to say that we're starting these in the pregnancy in Respect. It's owned by the case manager and social workers in Respect. It's a document that's owned by the mother that is then reviewed by the inpatient team, shared with DCF if mother gives permission, and then it's then passed on to the pediatric providers after delivery. And this seems to be working well for us over the past year. With Hep C, this is one area where we continue to have struggle with retention. So we've seen about 70% of our kids exposed to maternal hepatitis C, and you can see here that only less than half of them actually completed their work about to 18 months of age, that we were losing them along the way. And so some of the things that we've done to try to improve that is one is that we're testing all moms with substance use disorder and pregnancy. We're having the pediatric infectious disease nurse actually meet with the mother in the hospital to explain how critical it is that they continue this follow-up process, and they start seeing them about a month after delivery. A lot of this now we try to do within pediatric primary care because, again, the less visits they have to go to, doing it all in the same place, I think has really, really helped. We're also really trying to get the moms into treatment as well. So I think that as well can help us linking maternal and infant care. Ophtho as well, we have found a lot of them don't understand why there is this need for follow-up, and so they are at increased risk for things like nystagmus, strabismus. We've seen that the incidence about 10 to 15%, particularly in methadone-exposed infants, and so a routine evaluation at 4 to 6 months is what we have been recommending for this population. With EI, and again, I can take no credit for this work. This has all been led by Lily Peacock Chambers from Massachusetts. And you can see that even though we're getting a lot of referrals done in Massachusetts, that the number of babies that are actually enrolled just drops off every step of the way. We have found that infants that are in the hospital longer, in which there's maternal custody, that those infants tend to have higher rates of enrollment. There is this issue, which I know you guys mentioned earlier, with diagnosis. So you have to have a NOWS diagnosis to receive services in Massachusetts. So some of the things that we've done that I think have been really, really successful is we've linked this in with all other discharge appointments. So the person making the referral is the same person that's making all their other outpatient appointments when they leave, like the NICU or the ward, and it's part of the residence discharge checklist. And so I think this has really helped us to try to link EI in with everything else that's already happening on discharge. So it's just part of the checklist that you make sure you do before they go home. And that the reason for the referral is explained. I think that's a big one as well. Again, work led by Dr. Peacock Chambers, just looking at, she interviewed a lot of moms about why they were not better engaged with EI, and a lot of the things that we would suspect. There's a feeling of fear, guilt, and shame. They don't understand why it's needed. They feel judged. But eventually, through education, you're able to kind of break down the walls and see EI providers as advocates. But you can see along the way, why this is particularly challenging in this population. So I want to end by just sharing what I think has been really the most successful intervention for us being able to engage parents postpartum, which is that we have this integrated program. So it's basically, the best description I have is it's addiction-focused pediatric primary care. So they're a standard pediatric primary care clinic, but it's run by two pediatricians who just get it, and they want to work with these families. They see them every week. And within the clinic, they also integrate all of the subspecialty care in one place. So they'll do their Hep C follow-up and their eye follow-up. They have a developmental specialist. And they see them initially once a week, and then it's once a month, and just provides so much support. And so I took this from Epic. So this is their like pediatric primary care Epic template. And if you look at what's included, you can see this is about mom and dad, and it's just so wonderful because, this is the most important. If you're thinking about the outcome of the child, they're thinking about living situation, mom's mental health, is mom getting her Hep C care, and dad, there's a whole section focused on dad. So all of this is just so, so important. And so I think that I highly emphasize that all of our families come here, at least for the first year, when we know moms are such high risk for relapse. And I think this has made such a difference, is to identify those community pediatricians that are passionate about caring for these families and to preferentially send them to these clinics, because I think it's really made a big difference in keeping our moms engaged. And so, yeah, don't let go of them in that year. It's not over when you discharge them. Find those places where you can continue to engage them, particularly in the first 12 months after delivery. And so that is about it. So hopefully I've shared some things that have been helpful from our experiences in Massachusetts. I do want to thank everyone at Boston Medical Center, as well as from the PinQuin Collaborative. Again, our toolkit, you are welcome to look at if there's anything that may be helpful for your teams, and I would love to take any questions that you have.
Thank you, Elisha, so much. That is so inspiring and amazing. We have a couple questions here coming in through the chat. For others, feel free to chat in and I can read the questions off. The first set of questions are related to your breastfeeding guideline and recommendations. The first asks, are you requiring drug testing frequently to assess compliance with treatment while supporting breastfeeding, and who follows this? And then the second related is, how do you assess for synthetic opioid use, as many hospital urine tox tests miss this?
Yeah, so currently again, I can only speak to our breastfeeding guidelines at Boston Medical Center and what we do. So at our institution, the mothers have a toxicology screen at each encounter. So at every encounter during pregnancy, on admission to labor and delivery, and then at each postpartum visit. And so I think to answer your question, so we're relying on toxicology screen at delivery. If there is a concern where we need to have a follow-up, the way it typically works is that they're done within Respect, which is in the same system as ours, and it's really reliant on, we have our social work team, as well as, I guess, the pediatric providers are the ones making these decisions. So if there is a concern where we need to have someone do a repeat toxicology screen, that would be sort of up to the NICU team or pediatric team communicating with the outpatient provider. Though I would say that's not something that we require. So if we've deemed them eligible to breastfeed at the time of delivery, we do not require them to continue to show us every single week while they're in the hospital that they're continuing to have negative screens. And I think that was certainly a concern that providers had when we switched our guidelines. Like, how do you know that mom's not going to have a relapse while she's breastfeeding her baby? And so in order to address that, we looked at probably like 600 dyads and looked at our data across the 6 months postpartum, depending on when, they had a positive screen, and there was like zero correlation at all with this. And so really what we rely on, and I truly believe this, is we educate the mothers that if you have a relapse, do not breastfeed your baby. I truly believe the mothers do not want to hurt their babies. We have not seen in the history of us studying this over the past decade, instances when mom has relapsed and, there's an adverse outcome in the baby. Safe breastfeeding. If you have a relapse, do not breastfeed your baby. And we have certainly, and I think since we've changed the guideline, this is probably like 3-4 years ago, that has been the case. We have seen the moms that have used around the time of delivery choose not to breastfeed. They're choosing not to breastfeed. I think the women know when they're ready to do it. The women that are choosing to breastfeed and continuing have been highly successful in doing that. So I guess short answer, we don't require it. But if we did have a mom, for instance, who wanted to pump and dump and establish the sobriety, it would be up to the pediatrician obtaining those results from the outpatient provider and making that decision.
And then the
And
second
the
part of the
synthetic.
question was around, the synthetic opiate use.
Yeah, so I think I mean, the toxicology screens that we have do actually, we do send it out for specification for that. So we haven't had that particular issue at BMC with that. So I'm not sure exactly how to address that, to be honest. I mean, we typically have sent it out for the expanded urine panel to be able to specify which opiate it's positive for. I don't know if others have other experiences, but that has not been an issue for us.
Elisha, I had a question related to your plans of safe care model, which I think is incredible. That truly it's sort of this living document that starts in the prenatal period and continues onward. And something that we've been struggling with here in our state is how that information is then transmitted across the perinatal spectrum. And so even when completed in the prenatal period, does it live in mom's medical records? Is that information transmitted to baby records? Is there completion of that plans of safe care at birth hospitalization? And then is that information then transferred back to maternal records? So curious to know about sort of data and how it's captured and shared.
Yeah, so this has been a struggle for us, even though we're all in the same institution. So the way that we've done it is that, the prenatal social worker has the document. And of course, mom has a copy of the document, and the document lives in Project Respect. So they have a hard copy of the document for each of our mothers there. That document is then given to or shared with the inpatient social worker for the mother. And so it is not transferred into baby's chart because we can't do that. And so typically what we would usually do is that it's written in the infant's discharge summary. Yes, mom has a plan of safe care there, and mom then has to give us permission to be able to share that with the pediatric provider. Right, mom has to give permission to do that. And so typically, when they come to our SOFAR clinic, they're signing releases for share of information between, Project Respect and SOFAR. And so in that case, then the social worker would be able to share that information with the pediatric providers. But it's hard because you're right, we're not putting any of this in Epic. It's not shared between charts. And it's just, I think our one linking provider is that we have the social work team sort of crossing over between between prenatal and delivery, but it's very much reliant on the mother then giving permission for the OB providers to then share that with the pediatric team. And that's the way that we've been able to do it. And then once that happens, then the pediatric providers have it on their end, but actually none of it is within the electronic medical record. It's all on paper. But it's a challenge. I wish it was all in Epic and that it could be shared between mom and baby, but we have not been able to do that.
Yeah. All right. Well, thank you so much again for your time and expertise. I just want to add that, Meg Parker, your colleague in Boston Medical Center and my good friend, just emailed me and she said, Elisha is so impressive, great team scientist, and she literally has mentored over 50 medical students related to OUD, maternal infant dyad care. So truly, Elisha, we appreciate you here, but also the fact that you're mentoring sort of the next cohort of providers in caring for this high-risk population. So thank you so much, Elisha.
Bye. Thanks, guys.